Hello, I'm Dr. Ken Landau. Thanks for watching. Let's talk about premature ejaculation. It occurs irrespective of age or marital status, ethnicity, wealth, or education. In the overwhelming majority of men, it's not even a pathologic condition. It's a variation of normal. But men are reluctant to discuss it with their doctors, and fewer than 1 in 11 do because of embarrassment or the belief that there's no treatment. They'd much rather discuss a situation like erectile dysfunction, for which they know there's a treatment, Viagra and Cialis and Levitra. And doctors aren't necessarily very conversant with this situation that we call either premature ejaculation, early ejaculation, rapid ejaculation, or rapid climax. It was described over 1,500 years ago in the Kama Sutra, that's the 4th century Indian sex handbook, first modern report, 1887, but it really got on track in 1943 when Dr. Shapiro described what we now refer to as primary and secondary premature ejaculation. First, it's important to realize that a short ejaculation time, premature ejaculation, doesn't necessarily mean a lack of sexual enjoyment or a diminution in pleasure. Actually, the concept that it does comes from social media and social factors and cultural attitudes and unrealistic expectations and incorrect concepts of normal sexual function, and even through pornography. A short ejaculation time is typical in men who are beginning their sexual experiences in adolescence, early adulthood, among sexually inexperienced individuals, people with novel relationships. That's the norm. Male sexual response goes from excitement to erection to emission, and then ejaculation of the emission. And the ejaculation typically occurs with orgasm, but not necessarily so. And then there's resolution. The incidence, well, it's among the most common sexual disorders of men who are less than age 40 or 50. The number bandied about in the medical literature is that between 20 and 30% of men suffer the condition at least occasionally. In 1948, in the Kinsey report, it was said that 3/4 of men ejaculate within 2 minutes of penetration of the vagina. In more than 50% of sexual encounters, researchers at the University of Chicago studied men ranging from late adolescence to about age 60, and they found that 30% of men were noted to have premature ejaculation on at least one occurrence within the past year, and 10% of men had it on multiple occasions. A phone study looking at men in their 30s determined that the incidence was somewhere around 15-16%, but the most enlightening study showing how important the definition is and how important context is comes from South Korea. Men self-reported premature ejaculation in 20% of cases. They were given a questionnaire, a validated questionnaire that supposedly determines whether a person suffers from premature ejaculation. The number went from 20% down to 11%. Then they were given a stopwatch to see how long the intravaginal penetration was prior to ejaculation, and it was found that it was only abnormal in 3% of men. Well, the intravaginal ejaculation latency time is the major manner in which we describe what premature ejaculation is. Now, premature ejaculation has been thought to be due to a variety of emotional problems, anxiety or depression or marital distress or issues with the self-esteem, self-confidence. Probably has nothing to do with that. As a matter of fact, it seems that people who have premature ejaculation have no decrease in the quality of life, no decrease in the desire for sexual relations, no decrease in the frequency of sexual relations, but they do have more anxiety related to sex. It seems that for most men, it's the feeling that they have a lack of control of ejaculation that seems more important to the men than the duration of the sexual experience. Now, once upon a time in the 1940s, it was thought that premature ejaculation had something to do with psychiatric factors, emotional factors, psychosomatic factors. Probably doesn't have anything to do with that. Well, how do we define what normal ejaculation time is from intravaginal penetration to ejaculation? Well, do studies. And the studies have been done. It shows that on average, it's somewhere between 4 and 8 minutes. We have the 5-country study. And the 5-country study looked at men who were in their 40s, who, on average, who had normal relationships. And these men, if they happen to be from Turkey, their IELT, intravaginal ejaculation latency time, IELT, was between 3 and 4 minutes. Well, that was kind of short, but probably due to genetic reasons or socio-cultural reasons. Certainly compared to men from Spain and the Netherlands when it was 5 to 6 minutes, or men from the United States or the United Kingdom when it was 7 to 8 minutes. If we look at a mean without Turkey, excluding men from Turkey, it seems that on average between 6 and 7 minutes would be the typical intravaginal ejaculation latency time, but the number could go from less than half a minute to more than 40 minutes. And it doesn't seem to make any difference whether the men are circumcised or not, and it doesn't seem to change as men get older. Unfortunately, a lot of men confuse premature ejaculation and erectile dysfunction. Well, that's the problem. And then we have another problem where there is something known as pre-ejaculate. Pre-ejaculate is very common. It is a lubricating fluid secreted by glands in the urethra and at the base of the urethra known as Cowper's glands. And this occurs as a lubricating fluid. And some men confuse the pre-ejaculate with ejaculate. How do we define the condition? Well, we've gone through an awful lot of definitions from the World Health Organization, the International Classification of Diseases, Masters and Johnson International Society for Sexual Medicine, and they really haven't been all that helpful. Finally, the American Psychiatric Association took a stab at it, and they did pretty good. They started off some time ago with what's known as the DSM-3. That's the 3rd edition of the Diagnostic and Statistical Manual. That lists all the psychiatric diseases. And it's included in there. But it's not a psychiatric disease. It just happens to be in this particular book. And they made multiple changes over a period of time. And now we're at the DSM-5. And they describe it as ejaculation with minimal sexual stimulation. It occurs either before or shortly after penetration. It occurs before the person wishes. It is persistent. It occurs repetitively. It causes stress in the relationship, and there's no other explanation, no drugs or no relationship distress. And they further go on, and they divide it into mild, moderate, or severe. In mild premature ejaculation, ejaculation occurs within 30 to 60 seconds after vaginal penetration. When the condition is moderate, ejaculation occurs 15 to 30 seconds into the sexual activities. And when it's severe, ejaculation can occur before penetration of the vagina or within 15 seconds afterward. And they go on to divide it into generalized and limited forms. Generalized, that occurs with all individuals, all partners, all methods of stimulation, all situations, or limited forms. Maybe it's limited to a girlfriend, maybe it's limited to a wife. Well, there have also been several questionnaires that have been put out, the Premature Ejaculation Diagnostic Tool, Index of Premature Ejaculation. There's not all that great a correlation. And as a matter of fact, some of these tests label men as having premature ejaculation up to 25% of the time when their IELT is between 4 minutes and 25 minutes. That's normal to excessive. And in 12% of the cases, men are labeled normal when they have an intravaginal ejaculation latency time of just 2 minutes or less. Well, let's take a look at the women for a second. So if a person is having sexual intercourse with a woman and it takes a woman 25 to 35 minutes of stimulation before she has an orgasm, and the man has an average of 4 to 8 minutes, he's going to consider himself suffering from premature ejaculation when the problem might actually be the woman is suffering from delayed orgasm. And 30% of women don't achieve orgasm during sexual intercourse, regardless of the male latency. There's no structure inside the vagina that's the equivalent of the penis. And as a result, we know that intravaginal sexual intercourse might not cause an orgasm in a woman. It might require some stimulation of those areas of the body that seem to be highly sexually responsive. In intravaginal penetration intercourse, it seems that it takes somewhere between 12 and 25 minutes for a woman to reach orgasm. However, the time is very much shorter with self-pleasuring or with the partner pleasuring a woman. So not all women actually enjoy vaginal intercourse. Not all women enjoy prolonged vaginal intercourse. The concept of premature ejaculation seemed to have arisen from Waldinger in 1994, studying heterosexual men in stable relationships with vaginal intercourse, and he gave the men a stopwatch and said, "Here, go time yourself." And he found, first of all, that without the stopwatch, men would overestimate their IELT by a minute or more. Well, Waldinger divided premature ejaculation into 4 types. There's the primary or the lifelong type. That occurs in 1 to 2% of men. There's the secondary or acquired type. That occurs in about 4 to 5% of men. There's the variable or the occasional type that occurs in 10, 11, 12% of men, and the subjective type that occurs in about 5 or 6 or 7% of men. Now, the variable and the subjective types are much more common than the primary and the secondary types. So let's talk about the variable type. The variable type is when a person occasionally has episodes of premature ejaculation. It's inconsistent. There's no way of judging when it's going to occur. It's kind of like a football team or a tennis player or a golfer. Sometimes it's good, sometimes it's bad. Well, the prevalence of variable premature ejaculation is relatively high. There is absolutely no pathology that exists. There is no disease, no emotional problem. It just occurs, and the treatment is simply reassurance. Then there's the subjective type. The person complains to the doctor that he's suffering from premature ejaculation, but everything, including timing, is perfectly normal. There is no short time of intercourse. There is no problem. Those men just lack the appropriate education and reassurance. They need some counseling. Now, primary premature ejaculation occurs by definition with an intravaginal ejaculation latency time of less than a minute, and that's since sex started when a person was an adolescent or a young individual and continues to the present time. It is a persistent problem. It's a neurophysiological problem. Seems to have something to do with the genetics and seems to have something to do with the metabolism of serotonin in the body. These men lack voluntary control of their ejaculation. The concept is that these men are hyperstimulated. They develop early erection, they have premature ejaculation, and they have early detumescence or relaxation of the penis. These men, unfortunately, also seem to suffer from erectile dysfunction in about 50% of instances. So these men have a significant problem. They have a significant bother. They have very poor satisfaction with their sexual intercourse. And these men can be treated typically quite easily. Secondary premature ejaculation occurs in men who had normal intravaginal ejaculation latency time, and then all of a sudden, for some reason, typically during middle life, but it could occur anytime, they have ejaculation that occurs within 1 to 3 minutes after intravaginal penetration. The onset is, as I say, anytime. The prevalence is low. It's even easier to treat than the primary ejaculation. And it often is associated with erectile dysfunction, but it does not seem to be associated with the early erections or the early detumescence. Now, some men are not even aware that the loss of erection is normal after completion of sexual relationships. Well, typically in this condition, in the secondary premature ejaculation, there's some kind of an additional condition. So oftentimes it's prostatitis. So if the prostatitis is successfully treated, for instance, with an antibiotic, seems to go away, that's the end of the problem. Maybe due to hyperthyroidism, an overactive thyroid, again, treat it, goes away. Sometimes, unfortunately, it's associated with diabetes or multiple sclerosis or alcohol abuse. Alcohol and sex don't seem to like each other. About 25% of alcoholic men suffer from erectile dysfunction. 20% of them suffer from dysfunction achieving a satisfying orgasm. And about 20% suffer from premature ejaculation. The same kind of condition, by the way, can occur in men who are using cocaine or amphetamines, or men who are withdrawing from antidepressants. It also can occur in men with peripheral neuropathy and with men who have some problems with their spouses. The physiology suggests that in those primary and secondary types, there's the genetics, maybe oversensitivity of the genitalia, maybe it's got something to do with a nerve problem. We know that it has to do in many cases with the serotonin metabolism in the body, and even some epigenetics. Epigenetics, that's what happens from your mother's diet or some drug that the woman took during pregnancy, or even something that your grandmother took. That's something that goes along and passes. It isn't involving the gene, but it's involving the things that control the gene. Now, it's also important to realize that the serotonin metabolism is extraordinarily difficult and complicated, but that seems to be where a lot of the activity with premature ejaculation resides. However, there are also multiple other areas like dopamine or the cholinergic transportation or the adrenergic or the oxytocin pathways or the GABA pathways or nitric oxide. All of those seem to be very important. So how do we treat the condition? Well, we can treat it two ways, either psychological or behavioral or pharmacologic. There are no medicines that are licensed specifically in the United States at the present time for premature ejaculation. All of the drugs that are used off-label. And unfortunately, many individuals fall prey to false advertising. So psychotherapy, not appropriate. Sex counseling, well, it might be helpful to learn how to interact and to have maybe some more knowledge, but sex counseling probably isn't really all that great. Cognitive behavioral therapy, well, unfortunately, again, doesn't prove very helpful. Marriage counseling, it's not a counseling issue. Counseling is awfully time-consuming and costly, and it doesn't really have the support of the drugs that we have to offer. But it can improve, as I say, the sexual skills or increase confidence or decrease performance anxiety, correct some interpersonal issues. But the treatment can be stimulating the muscles, using the muscles in the pelvis, the same kind of muscles that we use in women who suffer from urinary incontinence. We call these Kegel exercises, and the Kegel exercises can increase the IELT from, say, half a minute up to 2.5 or 3 minutes. That's a significant benefit, strengthening those pelvic floor muscles. And then there are a variety of techniques where during sexual activities the penis is withdrawn and you squeeze the tip, called simply the squeeze technique. You squeeze it for about 30 seconds, re-engage in sexual activities. When a man feels the period of inevitability is occurring, that's when the sexual activities are stopped in a squeeze, or simply they can stop and do nothing, stop moving. And then there's the sensate focus that was popular for a while. All of these require a man to identify the point of no return, the point of inevitability. And that can be achieved by self-pleasuring or by engaging with a sex partner. And you can determine when the point is going to occur that ejaculation is inevitable, and you can stop immediately before then. And if you stop immediately before then and use the squeeze technique or the stop-start technique, then that's helpful for some people, but it's very interruptive of sexual activities. So what do we have? Well, it seems like the nerves are overstimulated, so we could use a condom. Or we could use an over-the-counter lubricant that has some kind of an anesthetic in it, maybe a benzocaine. We could use K-wide duration male genital desensitizer or Stud 100 spray or EMLA or other similar drugs that are available over-the-counter at the grocery store or pharmacy. These medicines contain benzocaine or lidocaine or prilocaine or combinations of the bunch. Well, they all seem to work fairly well in some men, and they can increase the intravaginal ejaculation latency time, say from half a minute to 3.5 up to 6.5 minutes. And then interestingly, the selective serotonin reuptake inhibitors, these are drugs like Celexa or Lexapro or Prozac or Zoloft, they seem to work very well. The best studied is Paxil. Paxil's been used since 1970. And it appears that a dose of 20 milligrams to 40 milligrams is probably sufficient. There's no direct dose relationship. But unfortunately, for these drugs to work, they have to typically be taken regularly. You have to take them for at least a week or two prior to them working, and then you have to continue taking them. Now, for a few men, a very few men, they can take just one single Paxil about 5 hours before sexual activities, and that might be sufficient. But for the overwhelming majority of men, it has to be on a regular dose. These medicines increase sexual satisfaction, increase ejaculation control. Now, in men who don't have either primary or secondary premature ejaculation, in women and in men who have other conditions, or men who have depression, then taking these drugs can cause erectile dysfunction, decrease in the libido, or anorgasmia, lack of orgasm or lack of ejaculation. But in men with primary or secondary premature ejaculation, those side effects don't seem to occur. Now, everyone who takes an SSRI, one of those drugs like Paxil, Prozac, Zoloft, Celexa, they could have side effects. The typical side effects are fatigue or yawning or dry mouth or diarrhea or headache, or maybe when you stand up your blood pressure goes down, you perspire, you could have fainting episodes. And we've actually discovered a variety of sexual disorders that follow the selective serotonin reuptake inhibitors. So we have the post-SSRI sexual dysfunction syndrome. It's associated with erectile dysfunction, a decrease in sexual drive, premature ejaculation, weak orgasm. And we also have the restless genital syndrome and the persistent genital arousal syndrome. So there's some problems. But in other countries, there is an SSRI that's very short-acting and doesn't seem to be associated with any of those problems. And that's called duloxetine. And duloxetine, or Prevalence, is available in Europe, it's available in Asia, it's available in Mexico, but not available in the United States. A new drug application was submitted in 2004 to the FDA, has not been acted upon. The drug was discovered by Eli Lilly. They were going to use it as an antidepressant. They finally sold it to Johnson & Johnson, J&J, but they didn't progress further with the drug because its action was too short. The half-life was less than 24 hours. It was cleared very quickly, so it couldn't be used as an antidepressant taken once a day. But if you take the drug 1 to 3 hours before sex, it seems to, in many men, markedly improve premature ejaculation. And it doesn't have a lot of the side effects that taking the SSRIs on a regular basis might be associated with. So it seems good. Now, a lot of men stop taking it relatively early, often because of the cost or the disappointment that it really doesn't cure the disease, but it's a treatment for the disease, much as insulin is a treatment for diabetes. And you have to take it all of the time, at least all of the time you want to have sexual activities. Relatively few men discontinue it because of side effect. Now, interesting, the SSRIs may work by boosting the melatonin concentration in the bloodstream. In normal individuals, it's about 15 units. In people with primary premature ejaculation, it's only about 5 units. So 15 units in normal individuals, 5 units in men with premature ejaculation. Taking an SSRI increases the melatonin concentration to about normal. So the question is melatonin potentially a treatment for premature ejaculation? Some of the other relatives of the SSRIs, like Cymbalta or duloxetine, seems to work just as well, but Effexor doesn't seem to work too well. The old-fashioned tricyclic antidepressants, especially clomipramine, that seems to work pretty well. And in the spray form, it seems to be exceptionally well. It was used, or has been used ever since 1973, seems to work pretty well, but may cause nausea or dry mouth or erectile dysfunction. In some men, hot flashes, and it may be toxic to the heart in a small percentage of individuals. It seems to work on the serotonin metabolism. In some men, Viagra or Cialis or Levitra works. That's popular in other countries, and it seems to work quite well, often used in Australia as the sole treatment, even in men who don't have erectile dysfunction. In some men, it seems to work in conjunction with the SSRIs. Seems to be very good, can increase the IELT up to 6.5 minutes. Well, in some men, taking the medicines like Viagra or Cialis may not improve the IELT all that much, but it can increase the confidence and increase the perception of ejaculation control, and that's what men desire. Now, just thrown in for completeness, Tramadol, that's a narcotic that's used for pain, but it also works as an SNRI. It works like the antidepressants, and it seems to work on both the serotonin and the norepinephrine to boost the levels in the system, and it can increase the IELT by about 5 or 6-fold. It also is taken on demand. You don't take it all of the time, but that's probably a very dangerous route to go. Then there's Modafinil, and that's one of those drugs that's used for people who don't get a lot of sleep. Then there are alpha blockers for men who have enlarged prostates. Seems to work relatively well for some men. Then as we get a little further afield, we have biofeedback and we have electrostimulation, sort of the transcutaneous nerve stimulators. In South Korea, they're doing surgery. That's not appropriate. Probably the only country where they do it is in South Korea. But they also, in some places, inject the penis with hyaluronic acid, medicines like Juvederm or Restylane, to separate the skin from the nerves in some fashion. Doesn't seem to work very well. There are a lot of Chinese herbal preparation, and those preparations like Chinese yam or Chinese red sage or white peony or ginseng, individually or typically in mixtures, they've been claimed to help men, but they're not certainly very well studied. Acupuncture is another method of treatment, and so too is injection of Botox. That seems to work, but unfortunately it works for a very short period of time, and it probably is not cost effective or even appropriate for men to have injections of Botox into the penis for premature ejaculation. So overall, now you know what's available for premature ejaculation. You know that it's a relatively common condition, and you know that it's not a disease. It's overwhelmingly just a variation of normal for most men, And for some men, it's a genetic condition that has to do with the neurotransporters and the neurotransmitters inside the body. So at least we have a treatment. And the treatments actually work fairly well. Thanks for watching. I'm Dr. Ken Landau.